Okay. First of all, thank you so much for again being here on time. I am so glad to see you all again. Today we are going to talk about the medical aspects of abortion.
So, Pragya, you're inaudible.
Can't
So,
hear Pragya.
Hello.
yeah, now you're
Oh, was I not audible?
Just that last bit, you started saying today we are going to look at the medical aspects.
Okay. Yeah. So we're going to talk about the medical aspects on abortion and everything that we sort of came across in module three, which was on service delivery. And yeah, so I can probably introduce our speaker for today. We have Dr. Shubhashri Balakrishnan with us. Dr. Shubhashri is an obstetrician by training and has over 18 years of experience working in varied resource poor settings on maternal and reproductive health issues. She has been involved for over a decade with Rural Women's Social Education Center, a grassroots Dalit women's organization working on reproductive health and rights issues in Tamil Nadu, India. She is also a part of Common Health, a national level coalition in India working on maternal and reproductive health issues and safe abortion across several states in the country. Her areas of expertise include maternal health, sexual and reproductive health and rights, health systems, community based accountability for health, and gender and health. Um, Thank you so much, Dr. Shivashi, for being here with us today. Yeah, so I think the entire structure for this session would be that there are a few, questions that I would want you to address. And there are also certain questions that had cropped up while our participants were taking the course, and we would want probably if you could address those questions for us, that would also be very, very helpful. Before we start, I just want to say that it's not mandatory to keep your videos on, but if you can, and if your internet also supports it, please feel free to keep your videos on. Thank you. Um, so yeah, so let's get started. Um, so we were basically in our module three where we came across a lot of service delivery related topics. And so probably we could start by knowing or discussing a little about the various ways abortion can be performed, along with the costs that are incurred for these procedures, as well as a little bit on comprehensive abortion care in both public and private centers. So you could probably start by talking a little on the ways that abortion can be performed, and then we could go with the costs.
Okay. Thank you, Pragya, and I hope I'm audible. And thank you for this session. It's nice to see so many of you here on this evening. And um, given tomorrow is International Safe Abortion Day, a very kind of topical issue also for today. Okay, so to jump into the questions that you asked, so the first one is on the various ways in which an abortion can be performed, right? So now, an abortion, as you all would be aware, and I do know that you've had some initial videos and some I mean talking about the issue or giving you an introduction to the issue. An abortion is a termination of a pregnancy for whatever reason. So basically you're trying to put an end to a pregnancy. So that's in lay terms an abortion. So this can be performed by a few types of medical procedures. And there are broadly two categories of medical procedures to perform an abortion. One is through the use of tablets or pills, certain types of pills in a certain kind of, way in which they are consumed. And second is through minor surgical procedures. So I'll take you through each of these. So the first I said is through the use of pills, what we call medical abortion or medication abortion in some instances. Now, medical abortion is done through the use of two different kinds of pills. One is called mifepristone and the second is called misoprostol. Okay, so just for convenience and for ease of saying for those of us who may not be comfortable with, long medical names, I mean, Mifi and Miso. Okay, so these medications are given in a particular combination using a particular protocol, and that actually causes the termination of the pregnancy. So what these medications do is, one, to kind of cut off the hormonal supply that is necessary for the fetus to thrive and grow, and then cause the uterus to contract, so the womb to actually contract and push the pregnancy out. So so this is broadly what these pills do. And Mifi and Miso in India are licensed to be used up to the law allows Mifi and Miso to be used for an abortion up to what we call 7 weeks of pregnancy or 49 days of pregnancy. This is usually calculated from the first day of the last menstrual period. So from the first day of the last period that the person had, if the pregnancy is up to 49 days, then the law allows Mifi and Miso to be used in India to terminate that pregnancy. Now, this is the law in India, but internationally, actually, medical science has kind of pushed the limits a little more. And even slightly later periods of pregnancy, Mifi and Miso have been shown to be safe to terminate a pregnancy. But in India, currently, the law only allows us to use it up to 49 days. So that is one. Also, just to kind of, sum up the thing, a medication abortion, if used according to protocol, is very safe and also very effective. So up to say 9 weeks of pregnancy or up to 63 days of pregnancy, which is what WHO usually recommends, or internationally the guidelines recommend. The medication abortion's effectiveness is what we call 98 to 99%. What that means is, if 100 people want to terminate a pregnancy and use the medication pills, the Mifi and Miso pills, according to the recommended protocol that is there, in the recommended dosage, in the correct protocol, using the correct protocol, then 98 to 99 of those 100 people would be able to successfully abort the pregnancy just by the use of these pills. There may be one or two who may need additional procedures or additional support, either in the form of more medication or in the form of minor surgical procedures, for that pregnancy to be terminated. But in 98 to 99, so a vast majority actually, the medication pills alone would be sufficient. So this is about the first part, which is the medical abortion through the use of pills. The second broad category of methods that we use to terminate a pregnancy is through minor surgical procedures. Now, these basically entail introduction of a surgical instrument, a small instrument, into the uterus, into the womb, through the mouth of the uterus. So through the vagina, through the mouth of the uterus, into the womb, and then basically sucking out that pregnancy and removing that pregnancy. Now, this is called vacuum aspiration, either a manual vacuum aspiration, or I mean, there are different ways in which to do the vacuum aspiration. And these are usually effective up to almost 14 to 15 weeks of pregnancy. So again, starting from the first day of the last menstrual period up to 14 to 15 weeks of pregnancy, a vacuum aspiration can be done. Now, beyond 14 to 15 weeks, we use other methods, because by then the pregnancy is a little more advanced and we need to use some other methods, which could be a combination of medication and other surgical procedures to terminate the pregnancy. So these are broadly the methods that are used to terminate pregnancy. Also, just to say that the vacuum aspiration up till 14 to 15 weeks does not require actually general anesthesia or putting you to sleep. Okay, so basically it can be done as an outpatient, not as an outpatient procedure, but does not require overnight admission. So you could go in the morning for the procedure, have the procedure, stay for a few hours in the hospital and come back the same day home. So it does not require overnight admission. The medication abortion, on the other hand, the use of pills could be done even at home. So once you've consulted a medical provider and who's found that it's okay for you to use medication abortion, and then has prescribed the pills, and once you've understood how to use the pills, they could be used by the person who's undergoing the abortion in their own home also, if they choose to do it that way. So that's the difference between the two methods. The surgical procedure would need you to go to a hospital, but again, a vacuum aspiration up till around 14-15 weeks would not require overnight admission and could be done as a day procedure. So, Pragya, I don't know if there are any more details that you'd like me to add into
Yeah,
that.
maybe we could
Are
also
there?
talk about whether we have to visit a doctor for both the procedures. Is it absolutely necessary?
Yeah. Okay. So for the surgical, there are two things here. One is the law itself in India. The all abortions are governed by the law called Medical Termination of Pregnancy Act. And according to the Medical Termination of Pregnancy Act, abortions can be provided in India only by a doctor, by an allopathic doctor, an MBBS, somebody who has an MBBS degree, but not just an MBBS degree. The law also prescribes certain additional kind of either qualifications or training, which ensures that they have the skills to provide a abortion procedure safely. So therefore, the law in India legally allows an abortion only if it is done by an MBBS provider. So not consulting a doctor is number one, not allowed by law in India, number one. Second, over and above the law, there are also questions of safety. And therefore, of course, the surgical procedure will definitely need to be done by a qualified medical provider and a doctor. But even the medication pills, it is best to have it under medical supervision. So therefore it's best to consult a medical provider, understand whether the medication pills are suitable for you given the length of pregnancy, given other conditions, etc., and then get a prescription for the medication drugs, because legally the medication drugs are to be sold only with the prescription of a doctor. Therefore, you would need a valid prescription from a qualified MBBS doctor to get the medication pills, which then, after which you can then use it at your own home or wherever you choose to use it. So that is the thing. So both in terms of legality of what is allowed under the law and in terms of medical safety, it's best to use both methods, either the medication method or the surgical method, under the supervision and the guidance of a medical provider. And by that, I mean, as per the law in India, an MBBS doctor.
Okay, thank you so much, doctor. So after that, probably we could also talk about the cost, which is, I mean, for it is a sort of knowledge which I kind of find it difficult to find on the internet, and there are varying sort of numbers that are given with respect to how much does it cost to have an abortion. So could you please tell us what are the costs and how do they differ across, say, public and private facilities?
Okay, so this is actually a very difficult question, Pragya, because there really is no uniform standard cost. So basically, we need to understand that abortion services are provided both within the public sector, that is the government hospital system, and in the private sector, that is private clinics and hospitals. Now, the law says that all government hospitals are considered by the law, so they don't have to get special permission to provide, or license to provide these services. They are considered suitable and equipped enough to provide services. On the other hand, private clinics who want to provide abortion services need to get a license under the Medical Termination of Pregnancy Act from a district level committee. And once they get that license, so the license is provided based on kind of, examining and inspecting whether they have the adequate equipment, to have the adequate, personnel, which are all laid out in the law, and whether they fulfill those conditions, and basically to see whether they will be able to provide the procedure in a safe manner. And then they are licensed to provide that service. So you have both these categories of providers, a government provider and a private provider. Now, within the government system, everything is essentially supposed to be free. Okay, but usually it does not work out like that. The service itself probably may be free, but there are lots of instances where people have to pay informal payments, what we call informal payments. But here, you have to pay here at the door, to the ward attendant, to somebody else, to somebody else. So those informal payments just add up. But over and above the informal payments, you have what are called the other kind of costs that are involved. So transport, going to the facility, maybe going not once but maybe more than once. Somebody needs to accompany you to go to the facility. Food when you are there. So there are lots of these different things that are there. And the issue here is that in the government facilities, usually abortion is not available at the lower level facilities, that is the primary level, the primary health center, or things that are lower on the ground and close to people's homes. They usually only available at the sub-district and district level. So especially for a person who lives in a rural area, say, or a remote area, they'll have to travel all the way up to the sub-district or the district level to get this service. And then that adds to the added complexities and costs that are connected with that. So while in the government system it's essentially free, there are these additional costs that are there. In the private system, unfortunately, there are no regulation of costs. Okay, so the medical abortion pills themselves, so they come in a combination pack of 1 tablet of Mifi and 4 tablets of Miso, which is the combination that's usually required to have an abortion till about till about 49 days or 63 days, which you take. Now that combi pack, based on the different brands, comes up to somewhere close to 400 rupees, or even slightly less than that, somewhere between 350 to 400 rupees. But like I said, you can get these tablets only on the basis of a prescription, for which you will need to consult a doctor. So then the doctor's fees, that will vary depending on who the doctor is. So if you go to a big corporate hospital, then your consultation fees are going to be much higher than what would be in a smaller town or a smaller hospital. So that is going to be completely varied. In addition, sometimes in the private setting especially, people are asked to do procedures, investigations before they prescribe these tablets. Usually these procedures are unnecessary. So for example, a mandatory ultrasound that needs to be done before a medical abortion. Actually, if you look at guidelines, standard guidelines, an ultrasound is not mandatory. It is only required in certain clinical conditions where we are not sure whether the pregnancy is really fitting into that 49 days category, or it's slightly, or if you have based on our clinical examination, we have a suspicion that it is, say, more advanced, and therefore we are not sure whether the medication pill will work. So only in those conditions do we need an ultrasound. Otherwise, regular on a uniform fashion for every person who actually seeks a medication abortion, an ultrasound is not necessary. But very often these are asked for. And these vary from provider to provider. And unfortunately, there is no regulation of this in our country. And therefore, the cost, then these additional costs will also add up to the procedure. The third thing is, again, unfortunately, since there is no regulation, what we have found and what various studies have also found on the ground is that providers tend to an abortion is a procedure that a person usually seeks not under very easy circumstances. These are very difficult decisions, and people are usually in very distressed circumstances, faced with an unplanned pregnancy, an unwanted pregnancy, maybe out of marriage, maybe not in a socially acceptable situation. And therefore, then you seek an abortion service to terminate that pregnancy. And if you are in a situation where you are where you want to really keep that procedure confidential, or you are worried about stigma and those several of those other social issues that are kind of related to abortion, then providers are known to take advantage of that and therefore charge exorbitant exploitative rates. So so the more advanced in pregnancy that you seek a provider. If you're not married, if you're young, if you're single, it is very well known that healthcare providers then take advantage of those situations and charge exploitatively. So therefore, to go back to your question, Pragya, on costs, the cost could be anything. So the tablets just cost 400 rupees, but the cost then accrue based on the several other things. A surgical procedure similarly would vary depending on where you get the procedure done. It could be anywhere from say 1,500, 2,000 rupees, all the way to many thousands. So it would definitely vary from place to place. I think there was a question in the chat basically asking, should we check for authorization? Yes, a private sector, government hospital will not have an authorization. They are deemed to be authorized. Whereas any private hospital that you go, that is doing abortion, that is providing abortion services, is supposed to have an authorization, a license from the district level committee, and they're supposed to display that license. So it's supposed to be displayed in a public place in the waiting room, etc., framed on the wall. So therefore it is good to look for that, because then that means that at least some kind of oversight has gone into whether that facility is equipped and to provide a safe procedure. So it is good to ask for that authorization. Okay, I'll stop there. Pragya, let's.
Yeah. Thank you for pointing out that abortion is often, happening in very sensitive circumstances. And so I also want to just drop a trigger warning in case we are talking about something which is triggering for any one of you. There's another question on the chat box, which is, if in a situation we are denied the service on moral grounds by healthcare provider, can we sue them or file a complaint against them?
Well, I don't think so, because well, the legal situation in India is such that the Medical Termination of Pregnancy Act does not see abortion as a right of women or pregnant people. It basically looks at it as a service that is provided by a healthcare provider based on it's completely provider control. The provider decides whether the person fits into some of the conditions and clauses um, that are spelled out in the Medical Termination of Pregnancy Act, and then the provider decides whether the abortion service has to be provided or not. So it is not seen as a right in the act, in the law in India, unfortunately, and that then leaves you in a very, very difficult situation if a provider actually denies that service, because the provider has to make that decision in good faith according to the law, and it's very difficult to then challenge that good faith. So I doubt that would be possible to take legal action against them. Of course, you could kind of, um, well, it's a very sensitive issue, but bring it up to the media or ask questions. But I doubt it would be possible to sue them.
Thank
I'm sorry about that, but that's how the law is.
Thank you. Oh, there's another question. Is there any way of countering the exploitative rates that healthcare professionals often demand from vulnerable pregnant persons?
Well, the approaching the public sector is one way of doing it, but there are problems with the government sector also in terms of, like I said, abortion is usually a very sensitive issue, and people who seek abortions usually look for confidentiality, look for quick procedures, look for a lot of privacy, many of which are not upheld in government facilities, and therefore most people then choose to go to private sectors. Therefore, see, the thing about this seeking a service in such a vulnerable situation is that there is a huge power differential there, because the person who's seeking the procedure is in a very desperate situation. It also is a very time bound procedure, right? You don't want to wait for a couple of weeks to take legal action or sort out things, because then the procedure itself becomes I mean,
Um, Hello? Just a second, I'll try to reconnect. Hi, sorry, there might be some internet issue, but Dr. Shushi is joining in a while. Yeah. Till then, you can also drop in your questions. And yeah, Khushi, is there something that you would want to ask? I could note it down.
Yeah, I had a question. So
Mhm.
I was thinking if they could share some of their experience of ground on ground about teenage pregnancies and abortions. How has it been for them? And if they could share some real life cases or examples that could help us reflect on and understand better the ground reality of teenage pregnancies.
Yeah, Dr. Shubhashri is here, and I'll definitely ask them. Hello, Dr. Shubhashri, are you here?
Hello.
Yeah.
Yeah, I'm really sorry. There seems to be some network issues. I've logged into my phone now, so I can't therefore see the chat box. So please,
Yeah,
yeah, help me with that. Okay,
absolutely.
so sorry, we were talking about exploitative services from private sector. So it is, I mean, when actually seeking an abortion, a person is in such a distress situation that usually it's very very difficult to to address any of these issues at that particular time. But what can be done is to work with organizations which are working on abortion access on the ground, and address or some of these issues. I think the best way to go forward would be to make services more available and accessible in the public sector, because unfortunately the issue of exploitative rates in the private sector is not just restricted to abortion, right? There is really no regulation of the private sector in this country, and therefore to regulate just the abortion services or the charges that they do for that is going to be very very difficult. So I think the way to address that would actually be to strengthen the services in the public sector and more make them more sensitive to the needs of people who actually seek abortions, in terms of upholding confidentiality, privacy, etc.
Thank you. So there's another question on. So I think Bharti, I think the first part of your question, which says what are the ways you would encourage those seeking abortion to negotiate with their healthcare provider, would be answered a while later. But Dr. Shivashi, Bharti is also asking what has worked and what hasn't worked for in your experience of self advocacy for probably ensuring safer abortion and better sensitivity among healthcare providers.
Okay, so like I said, when you're an abortion seeker, sometimes these are very, very difficult issues to handle because you're dealing with multiple things at that particular point of time. I would say if you have any doubts about the provider being exploitative, then it would be best actually to seek an alternate provider at that particular point of time when you're seeking an abortion service. And then once the immediate need of the service itself is, over and gotten over with, and then to work with certain organizations which are working on the ground to then approach the provider and work on addressing some of those issues. Otherwise I think I'm sorry to sound so pessimistic about it, but I doubt that very much can be done at that particular point of time with a private provider. With the public sector, there are several accountability mechanisms that are in place, there are grievance redressal mechanisms in place that you can then take forward if you feel that the service that is provided is not of good quality, that care is not being provided in a dignified, respectful manner, or so things like that, or even denial of care, then there are ways and means within the public sector where you could definitely hold people accountable, take it up higher up in the system to file a complaint, etc. But with a private provider, that's going to be very very difficult.
Thank you. We will come back to your questions, but I just wanted to probably address one of the themes that we also discussed as a part of the module. And because you also mentioned that the cost during abortion, which is transport and or doctor visits, or if someone's accompanying the pregnant person. But what for you would be what for you would constitute of pre-abortion or post-abortion care? say for someone who's opting for both medical or surgical abortion. So what would you recommend as like pre or post abortion care? Yeah.
Okay, so in pre-abortion care, there are two big components. One is the medical care itself, and then a large part of the pre-abortion care is counseling. And by counseling, there are different meanings to counseling. I don't mean actually, trying to talk the person out of an abortion, and so those are also things that are done. That's not what I mean by counseling. Just to ensure that the person has made the decision with full understanding and information about what the abortion entails, that they know what their options are, and that they have gone through that, and just ensuring that it's not a forced, sometimes abortions can also be coerced, to understand, to just to ensure that the person who's seeking the abortion is doing it of their own free will, with full understanding of what what the consequences or the implications of terminating a pregnancy are. That's number one. Next is to take them through the counseling process, the different methods that are available. So if they've chosen to have an abortion, then given the period of pregnancy, what are the methods that are available to them, where they can access those methods, what are the advantages of each method, what are the possible side effects or complications from each method, what should they expect out of the abortion procedure, how long would they need to rest, say, post abortion, when would they need to come for, say, follow-up care post-abortion, about contraceptive methods. So somebody who's seeking an abortion obviously has had either an unplanned pregnancy or an unwanted pregnancy. So what is their need for contraception? Would they need contraception on an ongoing basis? What kind of contraception? And therefore then to help them kind of, make those choices and decisions regarding contraception too. So this is regarding what the counseling would entail. The medical care would entail basically a good history taking, what we call history taking. So understanding the circumstances of the woman, a medical history, what the last menstrual period was, what has been their sexual reproductive history earlier. So all of those would form part of the medical history taking. A good clinical examination, basically to check whether there is, say, they're anemic, whether there are any other medical issues, to check what the stage of the pregnancy is, how many weeks or months is the person, is the pregnancy itself, because that would have a bearing on the type of abortion that you provide. So that may include an examination of the abdomen and what we call a pelvic examination. So an internal examination, basically seeing what the size of the uterus is, to make a decision about how advanced the pregnancy is. So these would all be part of the pre-abortion care. And then the medical provider, after the medical examination, then discusses with the person what the different options for abortion are, and walks them through the different options, and then helps them make a decision on what they want to choose, and then provides them with the service. So if it's a medication pill, provides them with a prescription with detailed instructions on how to use the pills. If it's a surgical procedure, then helps them with choosing an appointment on when they need to come in for the surgical procedure, if they need to come on another day, or whether it's going to be done provided on the same day itself, and then what to expect, etc. So this would be part of the abortion procedure itself. Now post-abortion care would vary depending on the method of abortion that's been used, whether there have been any any complications are anticipated, whether so these that would be the post-abortion care. So usually if it's a straightforward medical abortion or a vacuum aspiration procedure early in pregnancy, then there may not need to be a follow-up visit, but there would be, the person is given very clear instructions on what to look for, and what are the signs that they should look out for. If they have which, they should immediately come back for a follow-up visit. For example, if they have fever, or if they have, say, pain in the abdomen, or if they have discharge that is not what is usually expected. So So these are then they are given these very clear instructions and asked to come back for a follow-up visit. Earlier with the medication abortion, we used to insist on a follow-up visit 14 days later, but that is now out of the guidelines as we are learning more and more about medication abortion. So usually for an uncomplicated abortion, there is no need for a follow-up visit, but there needs to be very, very clear instructions on what when a person needs to come back to the hospital, if at all needed. Post-abortion care also would again include provision of contraception, because like I said, a person who's seeking an abortion service probably has a need for ongoing contraception, and therefore to understand what those needs are and to help them choose a method of contraception. So that would be broadly the pre and post-abortion care.
Thank you. And this is also a question that is I just realized. So, does then comprehensive abortion care is it free in public health centers, or is just the abortion procedure supposed to be free? So,
You can't have just the abortion procedure. Abortion has to be a comprehensive abortion care. You can't just provide the procedure without providing counseling or the thing.
oh,
So it the whole comprehensive abortion care is supposed to be free in the public sector, but very often the counseling aspects are all missing or are of very poor quality, or like I said, counseling is taken as an excuse to browbeat the person into giving up the idea of abortion and continue the pregnancy. So all of these happen on the ground based on the different moral prejudices that providers may have. But ideally, any abortion procedure is supposed to be a comprehensive abortion procedure, which includes both pre and post-abortion care. Whether that's happening on the ground is definitely a question.
thank you. I also have two other questions which were very directly related to this theme. One is someone in the discussion forum wanted to know about the safety aspect of abortion with respect to the frequency of performing abortions. In a sense, how often can or should a person access medical and surgical abortion?
Okay, so there really is no medical, criteria as to how many times you can have a medication abortion or a surgical abortion. If performed in a safe manner, by that I mean with good technical quality, then an abortion procedure is a very, very safe procedure, especially in early pregnancy. And by that I mean in the first 3 to 4 months of pregnancy, up till the first 3 to 4 months of pregnancy, about 12 to 14 weeks or so. It's definitely a very, very safe procedure. And therefore, if performed well, multiple procedures should not have a major consequence in the long term if performed well, and that's the main kind of condition here. If performed in an unsafe manner, then an abortion can have long-term repercussions in terms of pelvic infection, leading to other consequences like inability to conceive again, etc., etc. But those are if an abortion is performed in an unsafe manner. It could, I mean, as you may be aware, unsafe abortions can even lead to death. Okay, if adequate care is not provided. And every year we estimate that anywhere between 8 to 10,000 women die in our country because of unsafe abortions. So yes, so if performed in a safe manner, then it shouldn't have any long-term repercussions. But having said that, if a person is needing abortions on a frequent basis or is needing to undergo multiple abortions, then there really is attention needs to be paid as to some underlying issues. Like I said, one, an ongoing need for contraception. Abortion cannot be used on a long-term basis as in lieu of a contraceptive method. So if somebody is having multiple unwanted pregnancies and is having to terminate those pregnancies, then that means that that person is probably in need of an ongoing form of contraception. Now, why that person is not using that ongoing form of contraception, whether they do not have access to contraception, whether they do not have information on what to use, or whether they are in a condition socially where they're not able to use contraception because they are in an abusive relationship or are in a violent relationship, These are all reasons why a person may not be able to use ongoing contraception and therefore may end up with multiple abortions. And then that needs to be looked at and addressed. So superficially, yes, medically, yes, if performed well, multiple abortions do not have a problem, but they may actually be a red flag for other underlying issues, like, the person being in a violent, abusive relationship. So that is something that definitely needs to be addressed.
The last question is that someone mentioned that there is another issue that is faced during the pre-abortion process, which is conducting an ultrasound. And abortion for unmarried women are legal in India now, but the ultrasound sort of compels to write their husband's or father's name. And so, if you could also tell us that if that's true, and if there's any way to sort of not you know, have that procedure done.
Okay, so you said abortions are legal for unmarried women now. Abortions have always been legal for unmarried women from the time, the Medical Termination of Pregnancy Act was passed. Marriage is not a preconditionality for having to undergo an abortion. Neither is age. Right, so you could be a minor and you could still get an abortion service. You could be not married and you could still get, according to the law. Okay, there are lots of social issues that are involved, true, but legally, neither is marriage nor is being kind of, an adult above 18 years of age a prerequisite for having undergoing an abortion. So that's one thing. The second is that I am not aware that, first of all, an ultrasound, like I said, is not a mandatory procedure to have before an abortion. So ultrasound is only indicated in certain conditions where if there is a kind of, a doubt based on clinical examination as to the gestation, as to the period of pregnancy, etc., is when we need to have an ultrasound to confirm. But otherwise, an ultrasound is not a mandatory requirement before every abortion. Therefore, to say that you definitely need to get an ultrasound is not something that is required. If a provider asks you that, please ask why the ultrasound is needed. What is the indication for the ultrasound, and why is it needed before you actually going for the ultrasound. So that's number one. Number two, I am not aware whether ultrasound forms actually require the name of the spouse. I'm really not sure of this. I can check up and get back to you on this. But if somebody is actually pressurizing you to do that, then I would then suggest that you seek an alternative provider, because there seem to be then issues with the way the person is actually handling the abortion. I know it's not easy. Finding even a single provider to provide you a service is actually difficult, and therefore to find an alternative provider adds to the difficulties. But at the same time, not having a sensitive provider or somebody who's following the law is also going to have long-term consequences on the abortion procedure itself, and therefore it may be best to even right away find an alternative provider if that is possible. But I'm not sure that an ultrasound requires the husband's or partner's name.
Okay, Dr. Shubhashri, because you mentioned that that abortions have been legal for anyone, even age is not a factor. But like we all know that the POXO Act kind of also overlaps with the MTP Act and creates a situation where, say, minors sort of face various legal barriers when it comes to accessing abortion, and therefore other social barriers. So, can you tell us a little bit about how service providers deal with abortion for people under 18 years of age? And you could also probably, I think someone also asked on the chat, that you could also share some of the on ground experiences of teenage pregnancies and abortions, and share some examples from your own experiences.
Okay, so yeah, you're very right that the POXO Act complicates matters because it criminalizes any sexual activity, even consensual sexual activity below the age of 18. And as providers, we are in a difficult situation because there is a requirement for mandatory reporting under the POCSO Act. So we have to report any suspicion of sexual activity under the age of 18, and pregnancy is evidence of sexual activity, right? And therefore, if a person comes with a pregnancy, whether they are seeking to terminate the pregnancy or whether they're even seeking antenatal care, continuing the pregnancy and pregnancy care, there is a requirement under POCSO to mandatorily report that to the police. And this definitely complicates the matter. But at the same time, as a healthcare provider, you also have a responsibility, an ethical responsibility to provide the service. Okay, so while I have a mandatory legal requirement to report that kind of the case or the situation to the police, at the same time I also have an ethical responsibility to provide the service that the person has come to me for. And therefore, if it is for termination of pregnancy, then it is my ethical responsibility to provide that service, whatever the legal requirements for mandatory reporting may or may not be. That's number one. The second is also, there is some of us also go with this thing that there is an agency on the part of the person. So for example, if a person is a rape survivor of sexual assault, and then comes to you with a pregnancy, and is under 18 years of age, or even over, there is still a mandatory reporting requirement. But if the person chooses not to, or makes an active choice not to do that, it would be against my ethical responsibility to report. But that's a gray area, because one is an ethical responsibility and other is a legal responsibility. But just here to say that as a healthcare provider, I do have a responsibility to provide the service that the person has come for. So even whatever the mandatory reporting requirements under POCSO may be, I would still need to go ahead and provide the service to the person. So nothing changes on that front. The Medical Termination of Pregnancy Act, if a person is under the age of 18, in order to provide the abortion service, I need the consent of the legal guardian as a provider. So that is again a complicating factor, because the person themselves under the age of 18 cannot legally provide consent, and therefore a legal guardian needs to be brought into the picture to provide consent to the procedure. And that is again a complicating factor under the law. So just to say that all laws are not respectful of reproductive rights. Neither is the Medical Termination of Pregnancy Act. I talked about it earlier also, that it's not framed from the kind of, a sense of abortion being the right of a woman. It is basically a service that is provided by a provider, and the law lays out conditions on who can provide, when, how, etc., etc. But similarly, most of the other laws are not rights respecting laws, and that does complicate matters if you're looking at it from a reproductive rights perspective. Yes.
Thank you. So moving on with another, I think, question which we all sort of, especially people who work with abortion advocacy and rights, kind of confront, is that patients themselves might internalize a lot of abortion stigma and taboos that go around, right? So as service providers, what are the ways that you yourself and other people, other service providers around you have done to ensure that these patients can access safe abortion services? And of course, counseling is a very big part, but whether there are other ways also that service providers themselves sort of advocate for safer abortion services and kind of tackle stigmas and taboos.
Okay, so one is, of course, like you said, at the level of counseling itself, when a person actually seeks, see, you also need to be aware that while an abortion procedure may lead to a lot of stigma, say guilt, or so many of those other emotions, which are, like I said, an abortion, it's not as if a person wakes up one morning and decides, okay, let me terminate this pregnancy. It's a well thought out decision. Usually under very difficult circumstances, where they have actually taken into account the different circumstances and context of their lives, and then made that decision. So first of all, as a healthcare provider, it's not our role to be judgmental of that decision, or to question or revisit that decision. All we do at that point of time is to ensure that the person has made this in a well thought out manner, and has understood the consequence, and is not being coerced into into terminating that pregnancy. So that is the role that we play at the time of counseling. Now, I also want to counterpose the other side. If a person is forced to continue an unwanted pregnancy, there are also consequences to that. It's not. There are physical consequences. There are emotional, mental health consequences. There are social consequences. There are economic consequences, and so continuing with an unwanted pregnancy is also not in the best interest of the pregnant person. And therefore, it's important to juxtapose these and during the counseling process to address that the person who's seeking an abortion, and to actually reaffirm their decision by saying, okay, so this is a choice that you've made, taking into account the different circumstances and conditions of your life. And if you're very sure about this choice, let me support you by providing that service. And as a healthcare provider, I think that is the role that a healthcare provider has to play. Now, coming to how can healthcare providers advocate for safe abortion services? I think there are multiple ways in which we can do it. I mean, one is, of course, working at policy levels and ensuring that policies and programs are made with a more in a more rights respecting way, are translated into the ground in more rights respecting way, making sure that services are available in the public sector in good quality, and by good quality, not just technical quality, but also quality measures that are important to the person who's seeking the abortion. Say, like I spoke about earlier, privacy, confidentiality, care with provided respectfully. So ensuring that those kinds of services are available. And the second thing that a service provider can do is also to work with other service providers to kind of address some of the issues that come out of what we call moral value clarification exercises that may come from religious have religious undertones, moral undertones, to work with other service providers to clarify on some of these issues, and ensure that whatever said and done, they're able to either provide that service, or if they themselves are not able to provide that service, at least to direct a person who's seeking the service or is needing the service to another provider who will be able to provide the service, so the person does not end up being denied or sent away without the service. So those are again some of the things that we can play. The third thing that we can do is also to work with medical education. So to work with young doctors as they are in their kind of period of training, both in the undergraduate and in the postgraduate period, to ensure that they are able to kind of understand the concept of reproductive rights. They understand the abortion as a key kind of component of reproductive rights, and are able to then provide the service, therefore, when they become service providers, in a more rights respecting manner. So these are some of the different ways that as healthcare providers we can work with different groups to ensure safe abortion services.
Because we are talking also about myths and sort of taboos, stigmas, misconceptions, there have been a few questions on those lines also. So one, there are four of them. So I could start by the first one, which is, so does abortion affect the period cycle in the longer run or make any noticeable change?
Okay, so in the longer run, no. Again, all of these are based on the assumption that the abortion was provided in a safe manner. So if a medically safe procedure, an abortion that's been done under medical supervision in a safe manner, the immediate next cycle could be delayed, could be because of the body is getting adjusted to the termination of pregnancy, the hormonal cycles are all getting readjusted. So the immediate next cycle could be slightly off key. But in the long run, it would not affect your periods. Okay.
The next question is how several, like 7 to 8 or 10 abortions can impact pregnant people. There's someone who says that my grandmother and my mother have gone through them. A huge reason being that husbands have refused to use condom or protection methods. They cannot even fathom the impact of all of this. There must be a limit to how many abortions a body can bear. They're sure that a lot will depend upon the method of abortion used and care taken post-abortion, but whether there are long-term impacts of having several abortions.
Yeah, we spoke about this earlier, right? So if the abortions are done in a safe manner, there really is no medical kind of reason for long-term impact. If they are in, but also remember that if you have multiple abortions, the chances of at least one or a few of them being done in an unsafe manner become higher, and therefore then long-term consequences is definitely a possibility. Again, I mean, I don't want to take a personal story and highlight something, but this does kind of go back to the earlier thing that a person needing multiple abortions is probably somebody who's in a relationship that is not supportive or is abusive, of it being a shared decision on preventing pregnancy or shared effort at preventing pregnancy in the between the couple or in the relationship, and that's obviously not happening. So again, multiple abortions are should be red flags for looking at underlying violence, domestic violence, abuse, etc. So just to point that out here.
Is it true that a pregnant person might also be subjected to the risk of forced sterilization procedures while seeking abortion services in a public healthcare facility?
Okay, so this is again something that I should have said earlier, but I didn't. And yes, public health facilities, one of the reasons people do not prefer to go to public health facilities is because public health facilities are known to make abortion service provision conditional to the acceptance of a contraceptive method. So unless you agree to, so the logic goes like this: you've come with an unwanted pregnancy, so you want me to provide you an abortion service. Okay, I'll provide you an abortion service, but what is the guarantee that you will not come back with an unwanted pregnancy? So therefore, you definitely need to use some contraception without actually understanding why, what the reason for the unwanted pregnancy is, what the underlying circumstances of the person's life are, making the contraception a choice, that they make, but rather than do that, it's forced on them and made a condition to provision of the service. And usually usually the contraception that is kind of insisted on or coerced is a more long acting form of contraception. So either a intrauterine contraceptive device like a copper T or a sterilization procedure. So this is definitely a big problem in many public health facilities, that the abortion service provision is conditional to acceptance of some contraceptive method or the other, and that is definitely a violation of the person's rights. So yes.
And the last one is that, is there any evidence of multiple abortions which are carried out safely being linked to infertility at a later point?
Does multiple abortions lead to infertility? Is that the question? Okay, so
Yeah,
again,
even
if
if they are
abortions
carried out safely.
yeah, if even if carried out safely. Yeah, okay. So see, if abortions are carried out safely, they really are, like I said, very, very safe procedures, especially now with the recent medical advances and the newer methods of abortion, the medication pills and the vacuum aspiration methods, which are more modern methods of abortion. They really are very, very safe procedures. So there should not be any long-term consequence. Having said that, if the abortion is done in an unsafe manner, then it can result in pelvic infection, can result in long-term consequences, including infertility. So if the abortion is performed safely, then that it so people are usually cautioned of an abortion, saying, oh, but you would then become infertile, etc. That is really not true. If you get the abortion done from a qualified provider in a good kind of setting, in a safe manner.
Thank you, Dr. Shubhashri. Okay, so moving on to questions, like there have been multiple questions on advocacy and how healthcare providers also make a good part of that of advocacy in abortion-related issues in our country. Maybe we can first talk about how can service providers themselves challenge abortion stigma and taboos perpetuated by the healthcare system, and maybe if you could also tell us what role do abortion providers play in advocacy and policy making in our country, and whether you're also part of, like, whether there are groups like these who sort of bring all abortion providers together and sort of try to sensitize them and include them in active policy making to ensure better, affirmative, safe services? Uh,
Okay, so well, to broadly answer your question, there has not been any large movement by abortion service providers to actually form, say, a pressure group or an advocacy group or things like that. FOXY, which is the Federation of Obstetricians and I mean, it's a collective of obstetricians gynecologists in India. For that, as an organization, FOXY has been doing some advocacy with the government, with the ministry at the central level, including with the drafting of the new amendments to the MTP Act, etc. Um, the amendments that were drafted into 2014. So there is an active group within FOXY which has been playing the role of advocacy for safer abortion services. But beyond that, there really is not much movement of abortion service providers themselves in being part of many advocacy efforts. But I do agree with you that in any advocacy efforts on safe abortion, there is a need to partner with abortion service providers in order to do that. There are organizations that have been working across the country that are trying to train service providers, that are trying to do values clarification exercises with service providers, basically to increase the kind of number of providers who provide the services, to increase access to abortion services. IPAS is one organization, YP is another. Common Health has been working with different organizations. So there have been organizations that have been working on the ground, but in terms of a large momentum of service providers actually influencing policy, I don't see very much happening apart from FOXY's intervention.
Yeah, so we could also probably address some questions on the same. So I think Apurva says that it's almost always the women who are blamed and shamed for having multiple abortions, even by healthcare providers. So how do we counter that narrative while advocating for safe abortion?
Okay, so like I said, many of these uh, uh, taboos and stigma and everything comes from very internalized patriarchal kind of notions. And please understand that service providers are from the same larger society, and therefore carry the same prejudices and biases that society has. And there really is nothing in medical education or training that counters these prejudices. Rather, there are several aspects of the training which reinforce some of these prejudices and larger patriarchal notions that are prevalent in society. So it's not surprising that service providers actually carry these prejudices and therefore reflect the same prejudices in their service provision also. So there is a great need therefore to work with service providers, and like I said, both in service with professional organizations like obs gynes organizations, with young medical students as they're undergoing their medical education, to address some of these. So, for example, there's been a big intervention in Maharashtra on introducing gender in medical education and making sure that gender discriminatory attitudes that are kind of prevalent in medical, that are there in medical textbooks, are kind of removed, and more gender sensitive, gender reaffirming kind of attitudes are built in to medical students. And this has been an initiative in Maharashtra that has been going on for almost a decade now, by Sehat, the organization that's based in Bombay, along with the Maharashtra Medical Sciences University, the Maharashtra University of Health Sciences. And over a period of a decade or so, now this has become part of the curriculum all over Maharashtra. So initiatives like this are needed, basically, which address attitudes of healthcare providers, starting right from the period of medical education all the way up to when they are already existing service providers through professional associations, through government mechanisms, through for people within government service, etc. So these attitude, I mean, the things like values clarification, programs addressing attitudes are all some things that would help with addressing some of these.
The other question is there was a crowdsourced list of safe or non judgmental healthcare providers or gynecologists in urban settings. Are there any endorsed lists across different locations of this kind? And I hope that Bhati is referring to something that is endorsed by the medical community themselves.
There really is nothing, and this crowdsourced list was also not endorsed by the medical community. It was something that was put together by users. But again, like you said, very urban centric, very, what shall I say, corporate hospital kind of setting centric. So may not be something that's applicable to, people who live in rural areas and more remote areas, or are in situations even in urban areas where they're not able to access these kinds of health facilities, which are usually very expensive. So there is a great need to actually put together a list like that. For example, I work with a grassroots organization, RUSEC, in northern Tamil Nadu. We ourselves are abortion service providers. We do provide services up to a certain gestational period in our own clinic there. But we also do have a list of, through our general work in the area and our presence in the area, we have a kind of list of providers across both in the public and the private sector around that area that we can refer our patients to, if people even in the community that we work in, if they need services. So there is a need to actually put together lists for these for different areas. And if you do have contacts with organizations working in different areas, this would definitely be a good effort to help people actually seek abortion. So if you ask me if there is a forget lists of even sensitive kind of medical providers, there aren't publicly available information. And if you need an abortion, where do you go? Forget the sensitivity part. I mean, even who provides abortion service in a particular area, there are really no lists. Public sector also, you do not know whether if you go to a government hospital, that hospital has an obscenity in place, whether they provide the service. So there really is no public information on where abortion services are provided. And usually somebody who needs an abortion will have to kind of ask around, word of mouth, find out where the service is provided before they reach, which then adds to the difficulties in accessing services. So lists like these would be very, very useful, and they definitely need to be put together. I would also go one step further and say the government also needs to, publicly put out information on at least which of the government facilities, offer services. And private sector also, the district level committee has to license the facilities. So there could be a publicly available list of which facilities are licensed to provide first trimester abortions, which facilities are licensed to provide second trimester abortions in a particular place. And that is currently not something that is there. So it may be worthwhile something to advocate for.
Thank you. So one of the things that also crops up when we talk about abortion is the denial of abortions, especially for people from different identity groups or unmarried young women. Sometimes even married women are denied abortion on the ground that, why would you even require now that you're married and you're supposed to have children? So, like you mentioned before, that one of the ways to sort of navigate through this is to find another abortion provider if you're denied abortions. But are there any other recommendations that you would like to give abortion seekers if they are denied abortions, especially say in the public sector? So, what would be the steps that they could take?
Like I said, it makes it very, very difficult because the law does not make it a right of a woman to actually go and ask for an abortion. So it is basically the provider who has to decide whether the a person fits into any. And just to recap, those 4 clauses are: if the continuation of pregnancy causes a grave threat to the physical or mental health of the woman, if the fetus has kind of a substantial anomaly or deformity that will make the once the fetus is born, the child that is born of that pregnancy will have a mental or physical kind of sequelae. If the pregnancy is because of rape or incest, and fourth is if there is failure of contraception. Okay, now it's up to the provider to decide whether you fit into any of these categories, and if the provider decides that you don't, then you really have no choice, and that's the problem with the law, right? So and because the law is not something that looks at this as a right, so there's very little scope for the person who's seeking the abortion to actually challenge that at that particular point of time. Okay, but if you do fit into any of these criteria, okay, so for example, if there is a fetal anomaly, or if the pregnancy is as a result of rape, um, uh, uh, well, in which case, I mean, if there is a police report, etc., etc., and there's still the kind of the service is being denied in the public sector, you could make a complaint to the superior authority. For example, at the district level, there is a somebody called a chief medical officer or a district health officer. It varies from state to state, who could be approached with the fact that the service has been denied, and then made sure that the service is provided. In the private sector, it becomes very, very difficult because there is really no accountability mechanism in the private sector. And like I said, the law is not something that favors the person who seeks the abortion to actually challenge some of these decisions. And therefore, then the only alternative left is to go to an alternate provider. The other option, of course, is to take the medical abortion pills over the counter, but that is again not something that the law allows, and not something that I would recommend in terms of medical safety either, because it would be best to have it under medical supervision. So therefore, to find a provider who's at least but that is under the very limited kind of circumstances of the pregnancy being very early. If it's slightly more advanced, then this is not going to work either. So those are the options that are available to a person if one provider denies them the service.
Since we're talking about denial of abortion, and this is something that we have also been working on. So, for in the last quarter, what?
Can I just interrupt there and just go back one step to the denial? The biggest problem with denial then is that the person is pushed to have an unsafe procedure. So like I said, you would probably then end up taking the pills over the counter, or go to a provider who's not qualified enough, or who's not, who's not qualified under the law to provide that service. Because when a person decides to have an abortion, usually, like I said, it's under very distressed circumstances, and they're usually desperate to have that procedure. So if a service provider denies them the service, then the person is actually pushed into, seeking a service that is unsafe. And that is a big problem with denial, and which is why we are trying to, so while I may sound very, what shall I say, despondent about what a person can do at that particular point of time if they're denied a service. At a larger level, I think there is really a need to work on denial, because then that then pushes the person to actually seek the abortion in a very unsafe manner, which can have absolutely horrific consequences. So that is the problem with denial, and therefore something that we all who are advocates of safe abortion services need to work towards, to have not have denial of services. Sorry, I just wanted to put it out there.
No, thank you so much. So what I was trying to talk about was that so last quarter we there was a project that YP sort of did, was on sex workers and abortion. And so a lot of the times what happens is that uh, pregnant people or abortion seekers are denied abortion on grounds of their identities also. And Dimple here also has put down a question where she says that she wants to learn a little bit more on the on-ground experiences of advocating abortions for vulnerable groups and marginalized populations. So groups like, say, sex workers, these groups, or people living with HIV, people with disabilities, they're often denied abortion on grounds of their identity or marginalization. So how do they how can they access abortion services, and also how can abortion providers also sort of ensure that they are provided with safe abortion services?
So one is, of course, for the communities themselves to organize and advocate and demand, so these services. Now, if they're really marginalized communities, sometimes they do not have the power to do it, and therefore they would need external support in the form of other organizations that are working with them. So that is something that really needs to be done. And like again I said, it is very, very difficult to intervene for the individual abortion seeker. But if this is a pattern that you're seeing, that particular groups are denied abortion services, then that is something that needs to be advocated on at a much larger level, number one. Second is, again, like I said earlier, advocacy would be much much easier and much more kind of, there are much higher chances of success if you're advocating for these services to be provided within the public system. Because the public system has a responsibility to provide these services. The state, the government has a responsibility to ensure that these services are provided, and has signed on to different international commitments. And therefore can be held legally accountable if these services are denied. And therefore, to form pressure groups, to form collectives of these marginalized communities, have external support from other organizations, and then demand and advocate for services from the public system would be the way to go forward. So especially the communities that you're speaking about, there is a lot of stigma and what shall I say, prejudices even amongst service providers. And these need to be kind of, addressed. It's not going to be an easy process. It's not going to happen overnight. And this is something that really needs on-ground work on a more long-term sustained basis.
Thank you. Bharti here asks that can you throw some light on service delivery for Indian nationals seeking abortion in countries outside India, and any or bottlenecks or issues due to ethnicity or nationality, if you know of any? Yeah.
Okay, I'm really not aware of this, but just to say that the abortion legal scenario is very different from country to country. So there are countries like, say, many of the Northern European countries, Scandinavia, UK, Canada, which have very, very progressive, liberal abortion laws, where, for example, Canada doesn't have an upper age gestational age limit to seeking abortion. Many of these countries have a situation where a woman can, a pregnant person can actually walk in and ask for an abortion without having to justify why they want to terminate that particular pregnancy. So in countries like that, the situation would be very, very different from, say, countries that have very, very regressive abortion laws. For example, some of the Middle East countries, which there are countries in which abortion is prohibited, even if the person is under very difficult circumstances. Some of the Latin American countries where abortion is not allowed, even if unless the life of the woman is in danger, even in situations of rape. So the abortion legal scenario varies from country to country, and WHO actually has a dashboard upon the web where it maps out these different legal contexts in a country. And then that would then influence what the experience of seeking an abortion in these countries would be. I'm not particularly aware of what I mean, if you're from a different if you're an Indian national going and seeking abortion in these countries, what the situation would be. I would presume that it would be the same as what the particular legal context in that particular country allows.
Thank you, Shivashi. Before moving on, I just also want to probably give a chance to our participants to sort of unmute themselves, and if there are any questions that you sort of have on whatever we have been discussing till now, yeah, you can probably raise your hand and unmute yourself, and we can have a discussion. Okay, So what we can do is like you can raise a hand at any point and let me know, and I can unmute you for your question. We also mentioned a lot of sexual violence and rape, and we also mentioned how um, often it is intricately sort of connected to abortion. Dr. Shubhashri, if you could also talk a little about how sexual violence, and rape is sort of navigated within, among service providers, and how do they sort of deal with such cases, and whether there are sensitivity programs that are available for them to sort of take these cases up in a more affirmative and safe manner. Yeah.
Okay, so over the last few years, there's been a lot of effort by different organizations that have been working on issues of sexual violence, and based on their advocacy from the Government of India Ministry also. And there are guidelines that have now been put out on how to, how should a medical provider actually engage with a person who's faced sexual assault or sexual violence, and both in terms of what the medical requirements of such care would be, and in terms of the medico-legal requirements. So in terms of documenting injuries, collecting evidence for future legal kind of use, medical legal use. So there are very clear guidelines that have been put out. I wouldn't say that these have reached all the way down the ground to all the providers. There have been efforts at training healthcare providers, but these have been very piecemeal. But there have been efforts at training healthcare providers in these guidelines, ensuring more sensitivity during the examination, etc. And specifically as related to abortion, I said the medical care to be provided. So the medical care for a person who's faced a sexual assault or sexual violence includes care to prevent sexually transmitted infections, care to prevent pregnancy, and if there is an unwanted pregnancy, the termination of pregnancy also, which is also a clause that is allowed under the law, under the Medical Termination of Pregnancy Act. So this is definitely part of the the guidelines that are there, as put out by the ministry itself in India, the Government of India. And but if you ask me whether it's reached all the way down to the ground, I wouldn't say yes. There's a long way to go there. But at least the first step is to have guidelines in place, and that they are there. So that's where we are.
The other question that I also had, and I'm sorry for bombarding with so many questions, is that very recently, I think Ayush, which is the Ayurveda section of service providers, have been included in as legitimate service providers for abortion.
No.
Okay.
No. So the 2014 amendments that were proposed, see, the amendments were proposed in 2014 and they've just been passed now in 2021. They've kind of, they've seen the light of day only now. The original amendments that were proposed in 2014 did have a proposed amendment to include, to widen the base of service providers to beyond the MBBS doctors that is only currently allowed in the Medical Termination of Pregnancy Act, to include both nurses and Ayush practitioners, so Ayurveda, homeopathy, Unani, etc. So alternative, other forms of medicine kind of, practitioners. But that has not come into the amendment now, that has been dropped. That proposal was again made because there are studies which show that, studies even conducted in India, which show that, these service providers can provide an abortion in a safe manner, provided they're given adequate training and they're supervised adequately, etc. They can provide them in as safe a manner as an allopathic doctor would do. So there are studies and there is evidence, research evidence to actually prove that, and that was the basis on which the amendments were proposed. But there was a lot of political opposition to widening that base, very much from the Indian Medical Association, also from the allopathic doctors themselves, as to opposing this move, and therefore that has not come into force. So currently, even with the 2021 amendments, only MBBS doctors and with specified additional qualifications or training are the only ones who are allowed to provide termination pregnancy services. So sorry to have interrupted you there, but that's where we are in the law.
Oh, thank you so much for correcting me. So I would also want to then know that how does then say the allopathy sort of also talks with the homeopathy, and like what whether service providers from the allopathic sort of space kind of also believe in those studies which say that abortions can be provided through Ayurveda or homeopathy, because it kind of also constitutes a huge part of abortions, myths and misconceptions, and a lot of those. I don't want to say quacks, but yeah, a lot of people in both rural and urban areas also try to perform abortion through Ayurveda or other methods which would not be, say, which are not, approved by the allopathic space. Yeah.
Okay, so when I say there is research evidence to show that Ayurvedic practitioners and the nurses can provide abortion, the research is on them using not Ayurveda or homeopathy or other traditional methods, but on them using modern medical methods. So can Ayurvedic doctors be trained to provide medication abortion through the use of MEFI and MISO, or through, can nurses be trained to do a vacuum aspiration procedure safely? So we are only talking about them providing modern medical methods, not traditional methods of abortion. Okay, so that is number one. But anyway, the law currently does not allow them to do that either. Okay, now going back to your question on, traditional methods of abortion. Some of these traditional methods of abortion, when I say that abortion is a very safe procedure, I'm talking about modern medical methods of abortion. And by that, I in vacuum aspiration done under medical supervision in a kind of a good safe setting, in a good quality safe setting. Now traditional methods, there are multiple traditional methods that have been documented across the country, using Ayurvedic pills, using other procedures, using herbs, using things inserted into the vagina, many of which can be very, very dangerous. When we say unsafe procedures, these are some of the procedures that we are referring to also, and therefore I would strongly warn anyone who's looking at any of these traditional procedures to not go in for those procedures. So unsafe abortion by these methods or by unqualified providers, and here I'm somebody who's very pro pluralistic systems and bringing in other systems of bringing in the good of all systems and integrating pluralistic care. But in terms of abortion care, there really is no evidence that these are safe methods. In fact, there is a lot of research to show that these can be unsafe methods, and therefore I would strongly discourage use of these methods. So just to clarify on that, and also to say that the law currently only allows MBBS providers to provide termination of pregnancy services.
Thank you so much, Doctor. So are there any other questions? Are there any other sort of clarifications that any of you would like to raise right now? The floor is open for any questions.
Hi,
Yeah, yes.
are there supply chain issues? If you do get a prescription and access to a pharmacy for the pills, and what kind of happens there? I'm going to stop with that. Yeah, sorry.
Yeah. There are definitely supply chain issues. Thanks for bringing that up, and that varies from state to state. Okay, because of two or three different kinds of reasons. One is a very moralistic kind of reason about, people coming to take abortion pills and then going and kind of, terminating their pregnancy. So there are these very moral policing kind of very moralistic kind of discourses that are there, and many pharmacies do not stock abortion pills for that reason. Number one. Number two, there has been a crackdown by several states on abortion pills because of the sex selective abortion kind of issue, and they feel that people buy pills over the counter and then terminate pregnancies for reasons of sex selection, for selecting for terminating a female fetus once they have a sex determination test done by ultrasound. There is not much evidence to show that the bulk of abortions happen in this way, but this is something that has been done by several states, for example, Maharashtra, etc. And therefore, there's been a crackdown on the availability of medical abortion pills. So all of these definitely affect the availability in pharmacies. The third thing that has happened because of this is that medical abortion pills are on what is called Schedule H, so you need a prescription. But very often states also, because of the earlier thing that I said, that this thing of people buying abortion pills and then having sex selective abortions, I mean that kind of idea, states are also hounding pharmacies. So asking them to produce prescriptions, asking them to produce records, harassing them, etc. So pharmacists feel that it's a needless kind of worry to kind of stock these drugs, and therefore then take the easy way out and do not stock these drugs. So there are definitely supply chain issues. There have been studies on that, and to show that in some states it's actually quite severe. The unavailability of the medication abortion pills. So yes, it's definitely an issue on the ground.
If I could follow that up with a question, so compounded with the supply chain issue, does the price vary across states for accessing?
The price shouldn't vary because the the MRP would be the same. But if there are informal payments that are charged by pharmacies, I am not aware of that. I am not aware of pharmacies charging exorbitantly for the drug, because they can't charge more than the the MRP that's
Right.
on the label. I'm not aware of that, but I do suppose it is possible that if you're really desperate and are not able to get the drug anywhere, that there could be a black market and people could sell it at exorbitant prices. But I haven't heard of that.
It's slightly tangential to the same question, though. There is also a similar issue with emergency contraceptive pills available, right?
Yeah. Absolutely, and that is also for very moral kind of overtones to the discourse, where again this thing about if emergency contraceptive pills are freely available, people go around having sex all the time kind of discourse, and therefore in some states, the state that I come from, Tamil Nadu, there's been a big moral policing on emergency contraceptive pills. It's very, very difficult to kind of get them from pharmacies. You're right.
Thank you, Bharti, for all the questions. And thank you for pointing that out. I think at YP also, in our work, as well as in general, when we advocate abortion, I think there's another sort of very, I mean, I personally also find it very difficult to answer. But Dr. Shubhashri, so do you think, do you advocate for self-administered abortion through pills? Because often that question comes up, that that people in can probably perform abortion by themselves, but the law sort of restricts that, and it kind of also mandates that we should consult a doctor before performing any abortion through any.
Okay. Yeah, let me put it like this. There is a lot of evidence that medication abortion can be safely self-administered. There is a lot of evidence around the world from literature, from studies that shows that medication abortion can be safely self-administered, provided the person, there are some checks and balances where the person is able to, safely assess their, gestation age, that is how far along in the pregnancy they are, or somebody helps them do that, and provided they have adequate information on how to use the pills, what to look for, when to seek medical care, etc., etc. If that is done, then there is a lot of evidence on self-administered use of medication abortion, and that it can be safe. But at the same time, like you said, the law in our country currently does not allow that for various reasons. And well, that's where we are. But yes, there is a lot of global evidence that it can be safely self-administered.
Thank you. Yeah. Are there any other questions from anyone else?
Can I follow up with what might seem a silly question? I wanted to understand, in terms of how you said to self-ascertain the length of the pregnancy. So supposing, especially when like pregnancy may have happened right before a period or during the period. So if one were to like estimate that and one were to make a choice based on that, would that be safe?
No, so usually we do not calculate the period of the pregnancy from the time of the intercourse. We do we calculate it only from the time of the last menstrual period, and that's a standard way of calculating it. So so irrespective of when the sexual activity has happened, the gestation, the period of pregnancy is usually calculated from the first day of the last menstrual period. So so that's how we do it. But this is usually only reliable if the cycles have been fairly regular. So if the cycles have been way irregular, then this method would then be kind of kind of uncertain, the period of pregnancy, which is when then the need for things like ultrasound, etc., would come in. But with somebody who's had fairly regular cycles, calculating from the first day of the last menstrual period would be a reasonable way to calculate the pregnancy, the period of gestation. And then going to a medical provider, I mean, and by a medical provider, I don't mean only a doctor. In India, by the law, it is a doctor, but several countries have worked with other providers. So for example, a nurse who would then be able to examine you and ascertain whether the period of gestation, I mean, by examination matches with what you're saying as calculated from your last period. And if both kind of, match and corroborate, then there is really no need to kind of, do any further investigations. But that kind of examination also helps and is part of the pre-abortion care that I spoke about earlier.
Okay, super, thanks.
Are there any other questions? All right. I mean, of course, if there are any other questions that say all of you couldn't have mentioned here, please feel free to sort of reach out to me, Shavik, or and I could, send them to Dr. Shubhashri, and we can sort of discuss it over emails or yeah. Sorry, there's a chat. Yeah. Okay. Yeah, I think we have kind of come to the end of the discussion, but before we close, I just also want Dr. Shubhashri to sort of, if there's anything that I missed discussing, or if there's something that you would want to sort of add from your experiences, please feel free to do that. Yeah.
No, not really, Pragya. I think it's been quite a kind of, a wide-ranging kind of, discussion. Well, I do realize from this conversation that there were lots of questions about, denial of services, refusal of services. And I understand that, this can be a very, very difficult kind of experience for somebody who's actually seeking a service like an abortion, which is a time-bound kind of thing, right? You can't wait for another month to kind of, seek that procedure or go hunting for that procedure. and therefore then can be a very, very difficult situation. Unfortunately, there aren't too many answers today to what can be done in a situation like that. And therefore, then the need, therefore, for all of us to kind of, advocate for safe abortion services being available more widely with better quality, being more accessible at a, in the public system, at much lower levels of the public system. And there have been kind of changes over the last several years. I should say many states now, medication abortion pills are available in primary health centers. There have been efforts to train doctors in, say, primary health centers and, taluka level community health centers, block level health centers to provide medication abortion, to provide manual vacuum aspiration procedures. So there have been efforts. It's not that nothing has been done. Things have changed over the last several years, and the availability of medical abortion, I mean, the fact that medical abortion pills have come into the fore over the last 25 years has also changed the landscape completely, because it's made abortion a much simpler, much safer kind of procedure that a woman can have, a person can have in their own homes. So that has definitely changed the landscape, but even so, a long way to go and lots to be done. So that's where we are.
Thank you so much, Doctor. Shavik, is there something that you also would want to add?
Yeah, this from my end. Thanks so much.
Okay. So yeah, thank you so much for participating and talking to us, Dr. Shubhashri. It was such an interactive session. Bharti is asking, can we refer people in Tamil Nadu or Chennai based to you? If so, how?
Yeah, you can share my number if necessary. Please reach out to me. I'm not currently based in Chennai, but I can put you in touch with people in other people in Chennai. Yes.
So what I could do is probably, and if you allow me to, Dr. Shubhashri, can I share your email address and your contact with the participants?
Yes, please do.
Okay. Thank you so much. But before we leave, I just want to sort of acknowledge that this has been such a great session. I am extremely sorry that I also had misinformation, and I'm very glad that those have been clarified. So thank you so much for being so patient with us, and thank you for talking to us and sort of clarifying all the doubts. I'm sure that in future also, if there are further clarifications required, that I can and we all can reach out to you.
Absolutely,
And
yes.
thank you so much. And thank you to all of you for being here and sort of asking questions and interacting with all of us. Next week, we have the last module, which is messaging around abortion. And so I hope that you all will sort of get to that. And I will also see you all next week. And till then, yeah, take care of yourselves, take care of your mental health. And yeah, tomorrow is International Safe Abortion Day. So I also just want to acknowledge that thank you for taking interest in abortion rights and advocacy in India as well as globally. And try to participate in all the happenings that will be conducted on Twitter, Facebook, Instagram, all over the social media, as well as in and around yourself, for advocating safe abortion services for everyone. Yeah, thank you so much, Dr. Shubhashri, and thank you all. Bye.
Thanks, everyone. Bye-bye.
Thank you so much, Dr. Suresh.
Thanks a lot. Bye bye.